Welcome to the presentation of the pathophysiology of a urinary tract infection. A urinary tract infection, UTI, refers to a symptomatic bacterial infection within the urinary tract. This includes the lower urinary tract infection, cystitis, which is an infection of the bladder, and urethritis, which is an inflammation of the urethra. A UTI can also be the upper urinary tract infection, acute pyelonephritis, which is an infection of the kidney. Periurethral colonization by the invading pathogen appears to be the initiating step in a cascade of events leading to a UTI. Most of the causative organisms are naturally present in the GI tract, which acts as a natural reservoir for potential UTIs. Pathogens of uncomplicated UTI infections are most commonly Escherichia coli in approximately 80% of cases, followed by Proteus mirabilis, Staphylococcus saprophyticus, and Klebsiella pneumoniae. There is a general agreement that for the best management of patients with UTI, it is important to distinguish between complicated and uncomplicated infections. Uncomplicated UTIs are among the most frequently encountered infections in the outpatient setting after respiratory tract infections. Uncomplicated UTIs include acute uncomplicated cystitis and acute uncomplicated pyelonephritis. Complicated infections include those involving the parenchyma, which is the pyelonephritis or prostatitis, and frequently occur in the setting of obstructive uropathy or after instrumentation. The presence of obstruction, stones, or high-pressure vesicoureteric reflux, perinephric abscess, life-threatening septicemia, or a combination of these predispose to kidney damage. Episodes may be refractory to therapy, often resulting in relapses and occasionally leading to significant sequelae such as sepsis, metastatic abscess, and rarely acute renal failure. UTIs may be considered complicated if it is found in certain patient populations, including the immunosuppressed, men, pregnant women, diabetics, those with a history of pyelonephritis, or those with structural abnormalities of the urinary tract. Except for the distal urethra, the urinary tract is normally sterile due to host defenses against bacterial colonization. After periurethral colonization, uropathogens gain access to the bladder via the urethra, to kidney via ureters, and to prostate via the ejaculatory ducts. The urethra and ureterovesical junction are mechanical barriers that prevent ascension. In the bladder, the organisms multiply, colonize the bladder mucosa, and invade mucosal surface. Although urine adequately supports the growth of most uropathogens, the bladder has several mechanisms that prevent bacteriuria. For example, there is a monopolysaccharide layer covering the bladder epithelium, and urine flow and bladder contraction serve to prevent stasis and colonization. Bladder infection sets the stage for subsequent migration to the kidneys, where organisms such as P. fimbriated E. coli adhere to renal tubular cells. Outside the setting of obstructive uropathy, this strain of E. coli is the most common cause of pyelonephritis. Other host factors that prevent a renal infection are high osmolality, high ammonium concentration, phagocytes, and high urine flow rate. Associations have been established between UTI and age, pregnancy, sexual intercourse, use of diaphragm and a spermicide, delayed postcoital micturition, menopause, and a history of recent UTI. Factors that do not seem to increase the risk of UTI include diet, use of tampons, clothing, and personal hygiene, including methods of wiping after defecation and bathing practices. The non-gender specific risk factors for UTI include post-void residual urine in the bladder, use of a catheter, disturbed peristalsis of the ureter, obstruction, decreased renal blood flow, foreign bodies in the urinary tract, anatomical abnormalities, fecal incontinence, and old age. There are, however, male-specific and female-specific risk factors for UTIs. The female ones include having a short urethra, enabling ascending UTIs, increased sexual activity, anal intercourse, use of a diaphragm and/or spermicides. Another risk factor is pregnancy, as pregnancy causes a hormone-induced dilation of the urinary tract. And finally, postmenopausal women. The decreased estrogen levels lead to atrophy of the vaginal mucous membranes, reduced colonization by lactobacilli, and increased vaginal colonization, which cause UTI. Male risk factors for UTI include missing circumcision, predisposing children with vesico-urethral reflux to recurrent UTI, a reduced secretion of zinc by the prostate, sex with an infected partner or anal intercourse, and foreskin diseases such as balanitis. The understanding of the pathogenesis and epidemiology of UTIs can facilitate early recognition and possible prevention of a UTI. Initially, the pathogen colonizes the periurethral area and ascends through the urethra upwards towards the bladder. Fimbria allow bladder epithelial cell attachment and penetration. Following penetration, bacteria continue to replicate and may form biofilms. Once sufficient bacterial colonization occurs, bacteria may ascend on the ureter towards the kidney. Fimbria may aid in the ascension process. Bacterial toxins may also play a role by inhibiting peristalsis by reducing the flow of urine. Infection of the renal parenchyma causes an inflammatory response called pyelonephritis. While infection of the renal parenchyma is usually the result of bacterial ascension, it can also occur from hematogenous spread. If the inflammatory cascade continues, tubular obstruction and damage occur, leading to interstitial edema, and this may lead to interstitial nephritis, causing acute kidney injury. So how does a UTI present itself? There are a variety of symptoms that can indicate a UTI. For example, dysuria due to acute inflammation of the bladder resulting in discomfort upon contraction during voiding, an increased frequency and urgency in urinating due to reduced bladder capacity due to inflammatory edema, causing decreased compliance and pain due to bladder distension. Hematuria, which can be due to irritated edematous urinary tract bleeding with voiding. Suprapubic tenderness due to palpation and compression of an inflamed edematous bladder. A patient may also present with chills and sweats and may have a fever. This could be due to the inflammatory cascade resulting in a febrile response. And finally, flank pain, which may radiate to the groin and is often described as a dull and constant pain. This could be due to sudden renal edema resulting in increased pressure and capsular distension.